Hello and welcome to the Sisters for Fitness Wellness Show. I'm Stephanie Gaines-Bryant. Today we're talking to Dr. Raj Shetty, and he is an interventional cardiologist and director of the Cardiac Cath Lab at University of Maryland Capital Regional Health. We're talking about heart health today, and let me just welcome you to our program.
Thank you.
And I want to begin by talking about the fact that women suffer at a disproportionate rate, or suffer at a high rate of heart disease, more than we've seen over the years. Why do you think we're suffering from heart disease more often?
So women in general have been the primary caregivers in the family. I feel primarily women put their health secondary to the rest of the family, and they don't look at the warning signs early enough. That may be one of the issues. But generally, African American women especially, as the data suggests, that are twice as likely as Caucasian women to have incidence of stroke especially, and heart disease. There are many factors in play. Obviously, lifestyle is a big issue, and there may be some genetic role in this also.
What should we be looking for as far as signs of heart disease go?
So the basic signs I think everybody should be aware of when you're talking about heart disease. If you're looking at presenting signs of an impending heart attack, some of these things are common across genders. If somebody is experiencing a crushing chest pain, which starts suddenly, that's a clear signal that you have to go.
And that's what, over the years, for example, years ago there was a show called Sanford and Son, and he always said that he was getting ready to have the big one, the big heart attack, and he'd clutch his chest and say, "Oh, Elizabeth, I think this is the big one." So over the years, that's what we think is the big sign, the big of someone getting ready to have a heart attack, but it's not always like that.
It is not always like that. In fact, the big heart attacks are less common than the smaller heart attacks or the atypical symptoms that we describe. So a sensation of impending doom, or just shortness of breath, heaviness in their chest, or sometimes I've had women present just with arm tingling or jaw tingling or jaw pain. So all these things could be signs of an impending heart attack, and they may not be very typical. The typical symptoms is somebody who experiences heaviness and crushing sensation that is just overwhelming. You get short of breath, you know there is something wrong. But a patient who presents to us with a 2-a-day history of having jaw pain or arm pain, which is nagging and it is continuously getting worse when they exert themselves, those are not very typical symptoms. Sometimes a lot of patients will present just with heartburn, and they actually get treated for heartburn for weeks at a time and then realize that heartburn was not a heartburn, that was a heart attack.
What are the genetic factors that go along with heart disease? For example, if your grandmother or your grandfather had heart disease, are you much more likely to have it?
Yes, especially if you have family members who have had heart disease at a young age, or have died suddenly of an unknown cause, which we then assume is probably a heart attack. At a young age. If you have family members in their 40s and 50s, especially women in their 40s and 50s who've had heart attack, for me that is a big red flag, that women generally don't present with heart issues before menopause, and if you have members in the family who've had heart problems or have had heart attacks at that age, before menopause, that is a big risk factor. It's a genetic risk factor.
So when you go for your regular checkup, if you're under 40, when should you start to take a look at this?
There's nothing clearly that describes at a particular age, but if you were to go to a physician at any age, you do get a panel of tests done. One of them is your cholesterol, and you obviously get your blood pressure checked, and your weight assessed, assess your lifestyle. So all these things, you add them up, and there is a risk scoring system that physicians use to predict a 10-year mortality with for a given individual. And based on that, as to where you fall in that risk score, is then we decide how to take this forward.
The cholesterol thing, that's become very confusing over the years. LDL,
LDL,
HDL, which one is the important number?
They're all important numbers. The numbers that we focus on the most to treat, or at least the numbers that we have interventions to help treat, is the LDL number. The LDL is, or quote unquote, the bad cholesterol. So that's the number that is easily treatable in the majority of the population. And that's the number that the treatments have shown to have to reduce the incidence of heart attack or prevent a heart attack in patients who have had a previous heart attack.
You know, cholesterol, that word has been demonized, so we don't realize there's a good cholesterol as well.
So the good cholesterol in your system is what we call the HDL. Now, HDL, in certain patient subgroups, they genetically have low levels of HDL, and that is in itself a risk for heart problems. And then there are some people who are blessed with very high levels of HDL and are protected from heart disease. There are certain things that you can do to increase your levels of HDL. Exercise is the most important thing. If you have regular exercise, it can increase HDL levels.
Well, let's talk about obesity and the role that obesity plays in heart disease. We do know that 1 in 5 African American women is either overweight or morbidly obese.
Right.
So that's a huge problem in the African American community particularly. What role does obesity play?
Obesity plays a huge role. Obesity leads to a host of chronic diseases that then contribute to development of heart problems. High blood pressure, sleep apnea, and high cholesterol, and all of these then contribute to developing heart disease and stroke. So I think overall, in an epidemic standpoint, I think obesity is the #1 killer if you have to pick something.
So what role does lifestyle play? You can live with heart disease, but there are changes that you need to make to your lifestyle.
I personally feel that lifestyle is extremely important and probably the most important change that you can make. The benefits a patient can achieve from lifestyle surpasses other medical interventions. And lifestyle is important even from a preventive aspect, and that should be the first focus, is to prevent heart disease. And then if you have been diagnosed with heart disease, then obviously lifestyle becomes even more important to prevent a second episode of a heart attack or a stroke.
Well, how likely are you after the first episode to have a second one?
Very likely. Your risk for stroke increases once you've had a previous stroke. You've already, once you've presented with it, the advantage of once you have had a stroke or a heart attack is then there is a red flag, you're seeking medical help, and then all these interventions come into play. The ideal situation is to prevent it in the first place. And the ideal place to start this is in childhood. So once you have addressed these issues in the childhood, then it becomes a lifelong habit of having exercise and diet be part of your daily regimen.
Are you seeing more children presenting with signs of heart disease?
Absolutely, yes. So you have increase in childhood obesity that reflects with increased early onset of high blood pressure, sleep apnea, heart failure, and all these things lead to heart disease, yes.
Let's talk about what types of medications, have things improved over the last 10 to 15 years as far as how you just said that lifestyle changes are a huge part of it, but have there been improvements as far as medicines go when it comes to treating that?
Yeah, so not just medical treatment, even interventional treatment has improved dramatically over the past few years. People, are living longer, living better, having less symptoms once they have been diagnosed or have had a heart attack versus in the past. We have managed to reduce incidence of heart failure once we have diagnosed somebody with congestive heart failure. There are new medications now out over the last 2 years which have proven to reduce death, and which is a big change because in the last 7 or 8 years we have not had new medications come into the market. There are new interventions that have come in that have helped patients. We've had now procedures to help patients have their valves replaced just going through the arteries instead of having the chest cracked open. So
yes, because of course back in the past, when you had a heart attack or whatever, it was very invasive, whatever process you had to go through. It's not so much.
It's
nowadays.
not so much. Now, especially in some centers, and including myself, we do procedures through the wrist. Before, we used to do it through the leg, and you had to lay flat after the procedure for many hours. Now, patients get it done through the wrist. They sit right up after the procedure. They can eat their meal after the procedure. They can walk around and potentially go home after an intervention on the same day if it is an elective intervention, yes.
We hear the terms blockage. You've got 20% blockage, you've got 80% blockage, you've got blockage in one valve opposed to the other. What does that mean?
So the analogy that one should make is it is like plumbing. Blockage is, you can think about it as a gunk or plaque that builds up in these pipes, and they prevent the flow of blood through these vessels. As the blood flow reduces, the heart is an organ like any other organ in the body. It requires blood to perform its primary function, that is to squeeze blood to the rest of the body. And once the heart gets a shortage of blood supply to perform its function, it generally cries out in pain or in heart failure. It doesn't squeeze as well. And these blockages can be corrected or taken care of, either if the symptoms are lifestyle limiting and you can't do your day-to-day activities. Usually patients end up getting a stent where we open up the blockage and restore flow back to that tissue. Or sometimes they end up having open heart surgery or bypass surgery if there are multiple blockages.
But it's, of course, all of it's very, very serious.
All of it, yes.
But it's not what it used to be.
The bypass surgery is still a bypass surgery. It's an open heart procedure, but I agree with you that the patient outcomes have improved dramatically. That is because it's a team effort now. It is not just having a surgery done. There are a lot of other subspecialties in medicine that have come together. Things are much more refined. Outcomes have improved, yes. And for the stent procedure, it is easier now if you're not having to go through the leg and you're going through the wrist. The risk of bleeding and all that having decreased significantly.
Now, you're here in Bowie. Your office is here in Bowie. Who are you seeing walk through your doors most often?
We see a wide spectrum of patients. We see the chronic patients who've had bypass surgery, valve replacement, stents who come on a regular basis. Then we see patients who come to the ER, young people who have come to the ER with chest pain, and then they get referred to us because the ER has said, well, you're not having a heart attack right now, but go see a cardiologist and get this thing checked out. We see patients who have been diagnosed with heart failure, and then they need to be managed more acutely or immediately. So we all see the wide spectrum of patients and wide age ranges also.
But are you seeing mainly people over 40, but you just said that you're seeing more young people come through your door?
So we do see a lot of young people come through the door, especially most of them have gone to the ER and then they've had some issues, and then the ER will tell them, well, it's nothing happening right now, go see a cardiologist and follow up.
What's the difference between a heart attack and a stroke?
So the heart attack, as the word implies, is something that is happening to the heart. So it is, as we talked earlier, you have a blockage in your heart that goes to the point that it completely blocks off the circulation to the heart. The heart has multiple arteries feeding it, and if one of them goes down, that part of the heart tissue dies, and that's a heart attack. A stroke is a similar process that happens in the brain, that a part of the brain suddenly does not get blood. The brain, also being an organ, requires blood for its function, and if you choke off blood supply to a part of the brain, that part of the brain dies, and that's a stroke. And if that affects some of your function, like movement, then that part doesn't start. You lose movement in that area, or it could be speech.
Both are debilitating, but in different ways.
Right.
I've seen, I have friends whose parents, a good friend whose parent had a stroke, and she is wheelchair bound, and also the whole speech thing, and that's because of the brain factor.
Correct. So the implications of a stroke is very dramatic. Sometimes people can have subtle stroke and it passes away, and that's a signal that there could be an impending large stroke coming down the line. Similarly, a heart attack, people don't, from an exteriorly, you can't tell if somebody has had a heart attack, but when they move about, their lifestyle is compromised. You have episodes of heart failure. They can't do the things that they were doing because the heart now is not squeezing as well as it should, because part of the heart muscle is now dead. So the implications are different, but the process is the same.
What about hypertension?
Hypertension is a risk factor for both of these. Obviously, it's a big risk factor in the African American population because the incidence of hypertension is so much larger. In fact, incidence of stroke and hypertension in the young African American population exceeds that of the general population by sometimes as higher as 20 times. So the hypertension is, I think, after obesity, the biggest risk factor for stroke.
And hypertension is the whole blood pressure.
Correct. Hypertension is high blood pressure.
And that's constant. That's something that's on a constant basis. Your pressure is running high. His
pressure is running high, yeah. And sometimes you go to a doctor's office and you're anxious and your pressures can be high. And you have to then, calm yourself down, get the blood pressure checked again. And some patients, almost sometimes 15 to 20% of the patients, the pressure remains high at the doctor's office regardless how long you wait. And you end up telling the patients to get the blood pressure checked at home, which I always do because I think that's the easier way, and the patients are more comfortable sitting at home and checking the blood pressure. And I tell the patients, don't go by the first reading, check the pressure again about a minute or 2 or 3 later, do 2 or 3 readings and take the number. Then once you get relaxed and once you get into the habit of checking your blood pressure regularly, then it's like brushing your teeth or something, and you're not anxious about it, and your numbers come down.
Should you take it on an everyday basis for like 30 days, for example, to really get a gauge what's normal for you?
Absolutely. Especially if you've been diagnosed or are in the process of being diagnosed with hypertension, then yes, you should do that, and you should bring those numbers to your physician's office every time, so the physician can then rely on those numbers rather than relying on a number that's taken in the office and rush, you're stressed, you're anxious, multiple questions are being asked, and checking your blood pressure.
And I think you should educate yourself. If you know that you are suffering from this, when you go into the doctor's office, you should know what's going on with you. Instead of whatever the doctor says, you should have your own knowledge of what's happening to your body.
I couldn't agree with you more. I think education, and everybody should, information is available. Yes, I understand sometimes it's overwhelming, the amount of information that's out there. But yes, everybody should make attempts to educate them. And some of these things are, basic changes, lifestyle, eating healthy, exercising. So those things are basic changes.
And how should you be eating?
Eating can get very controversial to a lot of people, but I still do believe the portion control is important. Staying away from fried food is very important. Reducing salt intake is very important. And I think those are the important keys, and increasing the amount of vegetables in your diet and decreasing dairy and meat consumption.
In the African American community, a lot of those comfort foods
Yeah.
are just things you grow up with and,
Right.
and that we consider very satisfying. You know, that fried chicken and the macaroni and cheese
Yeah, yeah.
and things like that. But like you said, portion control.
Right.
No one's saying that you have to completely do without those things. Right. It's just not overdoing it.
Yeah, yeah. Yeah, I think overindulgence, then it leads to obesity and then the problems that come with it. If you can control the portions or reward yourself with those kind of comfort foods occasionally and try to cook them in a way that you don't use the fat and the ingredients. You can tailor the ingredients to reduce the calorie content.
What does your waistline tell you about your heart health?
Yeah, so the waistline tells you a lot. So anybody with a, increased abdominal girth is an independent risk factor for incidence of heart attack.
Why?
And, the abdominal fat that you accumulate predisposes you to develop more atherosclerosis and more hypertension and more incidence of heart attacks. And there is something specific about the abdominal girth more than fat everywhere else in the body that is contributory.
Well, we know as we age, everyone puts on a little jiggle in the middle. So how can you be more mindful of that?
I again think prevention is the key, and trying to inoculate this in childhood to help understand young adults that this is coming down the line and you should be aware of that and conscious of that. Staying away from alcohol or reducing alcohol consumption is one of the ways you can do it.
What does alcohol have to do with it?
Alcohol is empty calories that you don't really need, and people drink alcohol socially. Once you start overindulging in alcohol, that's just calories that you just add on.
And also, you know, people don't think about the fact that soda.
Soda, yes, yeah. And with alcohol, it doesn't go just by alcohol. People tend to have snacks and stuff along with alcohol, and that adds.
I mean, you can't do one without
the other.
I can't do one without the other.
Yeah, yeah.
In wrapping up our discussion, what are some of the things that people should be mindful of, some of the things that people should look for when it comes to heart disease and knowing whether you're someone who is more at risk than your neighbor or your coworker?
I think having a regular doctor's visit is important, because that's where you get risk stratified, you get an assessment of your risk. I think it's a good question to ask your doctor what your 10-year risk is if you've never been diagnosed with heart issues to begin with, and using that number as a guideline to tailor therapy. Therapy for cholesterol, therapy for high blood pressure, because those things change. If you have a low 10-year risk, then you may not need the treatment with cholesterol medicine. But if you have a high 10-year risk, then you may need treatment for that. So I think having that discussion with your doctor is important. Seeing a cardiologist if you get diagnosed with a heart issue, like heart failure or heart attack or stroke, that's important. I think studies have shown that patients who have been diagnosed with heart failure do better when they are treated with, under a cardiologist. That
was my next question. What causes one patient to do better than the other? If you've got two patients with the same issues, which one succeeds more for you than the other?
A compliant patient is going to do better than a non-compliant patient. Patients who adhere to their medical regimen, adhere to the lifestyle changes that they need to do, obviously they will do much better.
Also, in wrapping up the discussion, like you said, there's just an overwhelming amount of information out here, especially when it comes to medications. Every other commercial you see on TV now is some kind of heart medication, some kind of pharmaceutical company promoting some medication. How do you know what's best?
I mean, that's where you should have that discussion with your healthcare provider, because you know, it is very confusing when you have multiple brands prescribe advertising, and people are trying to look up and seeing if they have those conditions, they don't have those conditions. I do get this all the time where patients come and say, doc, do I need this drug? And you should have that discussion with your healthcare provider. If you feel that there is a condition that has been described and you're aware of your condition and you are asking, I think it's a legitimate question to ask. I mean, that's the purpose of the advertisement, is to create awareness, and sometimes you have to have that discussion with your healthcare provider to get an answer.
Another thing, it's sometimes you look on the internet, you have these symptoms, and you'll go on a website, next thing you know, you think you're dying.
Yeah, that's one thing that I always tell patients not to do, is to try to identify your symptoms online, and because there's so much information, it's impossible to tease it out to come to a conclusion, and that's why you need to seek professional help rather than trying to self-diagnose.
Well, it's been a pleasure, and my next question, or the next question I'll ask you when you come back, is what is the cardiac cath lab?
Okay. So cardiac cath lab is where we do these procedures.
Okay.
So where we do interventions or stents. Yeah. So that's where these patients, when they come in with a heart attack, actually a place that should probably be touched on maybe for another day is when patients have chest pain and they come in with a heart attack or an impending heart attack, they get either flown in or transported to a facility that has a cardiac cath lab, that where a person like me would be able to go and open up those blocked arteries.
Okay, very good. It's been a pleasure having you. We've been talking to Dr. Raj Shetty, and he's an interventional cardiologist and the director of the Cardiac Cath Lab at the University of Maryland, Capital Regional Health. You've been watching the Sisters for Fitness Wellness Show. I'm Stephanie Gaines-Bryant. Have a great day.